Greetings to all the leaders of the railway section of the Indian Society of Anesthesiologists. It's indeed a great pleasure and privilege to be a part of your annual convention, which is done through the virtual platform. And I sincerely thank Dr. Kamakshi Sylvan, who has been in touch with me in making this talk a possibility. Anesthesiology services, a new normal amidst COVID pandemic would be the topic on which I'm going to deliberate in the next few minutes. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, a tertiary care referral center for trauma, orthopedics, reconstructive microvascular surgery, spine, and burns. The COVID virus has produced unparalleled uncertainties to every human being on earth, and more so for the fraternity of anesthesia, because anesthesiologists have been involved in the critically ill patients and patients who come for emergency surgeries who may be COVID positive or a suspect, or they've been in charge of procedures which need to be done on an emergency basis, like endotracheal intubations, tracheostomies, and cardiopulmonary resuscitation, making them highly vulnerable to become positive. One thing which seems to be like a oasis in this desert of challenges is, though the virus is quite penetrative, we can win over the virus by doing ordinary things with extraordinary discipline. So the extraordinary challenge posed by the virus could be done by each one of us in doing ordinary things with extraordinary discipline. But this pandemic has produced such a change that tomorrow is certain to be very different. And that is the reason why we should start reframing the future today. And as anesthesiologists, we have to reframe our entire perioperative care, starting from the pre-operative, pre-anesthetic assessment, prehabilitation, perioperative care, post-operative follow-up. Everything becomes a new normal. And all this is because of the aerosols that are generated from one person, which becomes infective, resulting in another person from falling sick. And we as anesthesiologists are very, very closely involved in patients, especially the aerosols, because of the process of intubation and CPR. So many of the hospitals now in India have started to go in for starting their elective surgical procedures. The first few months, many of the units closed down the elective surgeries and were doing emergency surgeries. And now most of the center have started opening for elective surgeries. As I'm speaking today, we are realizing that the second wave has hit the northern part of India, especially New Delhi, Gujarat, Rajasthan have got increased number of COVID positive cases. And at any point of time, the entire country possibly can get engulfed in another wave. So it becomes pertinent that we need to create strict protocols to do our surgical procedures. In our institution, during this pandemic, we have done close to 13,000 surgeries starting from the month of March until now. And this includes emergency and elective surgeries. And the simple concept that we have followed in making this a possibility is the moat concept, where in olden days, the castle used to be protected from the enemy by the moat concept. And similar moat concept we used in our hospital: deepen the moat, narrow the drawbridge, and restock the alligator. What does this actually mean? It actually means that you form certain protocols to prevent your hospital from getting infected. The first thing is to decrease the number of people who are entering into the campus of the hospital. And number two is restricting the number of entries into the hospital. From 3 entries, we have narrowed down to 1 entry. And in every entry, we have made sure that hand hygiene, temperature monitoring, patient having a mask in hand, and physical distancing is practiced with diligence, which makes us free from healthcare workers getting infected or trying to minimize the healthcare workers from getting infected. So the protocol that we followed was we have a separate entrance for all the trauma that comes inside. Before doing the COVID results, before the COVID results come, we make sure that all these patients are received in the casualty, and through a separate entrance, they go to a dedicated and isolated COVID ward. No other investigation is done except if it's an emergency. And once the COVID result comes, which takes about 6 hours, and the test we do is RT-PCR. Once it comes negative, then we take this patient for all the other investigations, including X-rays, blood investigations, and post them for surgical procedures. The only difference between these emergencies and electives is in emergency surgery, we do not wait, because if it's life-saving emergency, we go ahead and do the surgical procedure with full PPE. So this is the protocol that we have followed. And in the 4th floor, where we do all the emergency surgeries, 6 operating rooms are dedicated for the suspect or possible COVID patients before the results come. And all the staff nurses and the doctors there are in full PPE. Whereas the other 6 theaters in the same floor but a different block will have the elective surgeries going on. And here the patients are RT-PCR tested, and we make sure that there is no mix of both the patient nor their attender, and no cross-infection takes place between these 2 groups. And it's very important that we make sure that every person who is entering this hospital will have a triple-layered surgical face mask as a basic minimum, because cloth masks were used by many before, but we know that in this pandemic, when the number of cases is on the rise, it's very crucial to have a 3-ply surgical mask, so which has been mandated in our unit. As an anesthesiologist, we need to get involved in several aspects of the administrative work to make sure that it's a well-oiled machinery. So all the railway hospitals across India should have strict protocols and guidelines formulated based upon their infrastructure, and the team should be formed with a surgeon, an anesthesiologist, a microbiologist, and an infection disease specialist, the head nurse of the unit, and the administrative head. So all the protocols to be formulated by them. And as an anesthesiologist, when we involved in the pre-anesthetic evaluation, I think one of the most important thing is to make sure that the COVID test is done. And in our institution, it is RT-PCR. Or if it is RT-PCR negative, we go ahead and do the surgical procedure. If the RT-PCR is positive, then if it's not an emergency, the surgery is postponed for 14 days. This is the current global standard. But you may be challenged. There are occasions when the RT-PCR is negative, but patient might have symptoms of possible COVID, like respiratory infection, headache, fever, loss of smell, loss of taste. And in this case, to make a decision whether to go ahead or not with the surgery, we get a high resolution CT scan done. And if the CT is normal, we go ahead with the surgical procedure. But if you find the ground glass appearance, which possibly indicates a COVID, in spite of RT-PCR negative, then we postpone the case for 14 days. So the take-home message is, if they are positive and if the surgery can wait, then we need to wait for 2 weeks. 2 weeks is because of the fact that after 2 weeks, the patient becomes no more infective. Another point, few patients may be RT-PCR positive even after 2 weeks, but they are not infective. That's why several units have decided that they won't repeat an RT-PCR after 2 weeks before they take them for surgery. And the next challenge is the airway assessment. So now it has become a dictum that airway assessment done in OPDs or in pre-anesthetic clinic with a patient who is 6 feet apart, or an airway assessment is never done and the operating room is equipped with all the airway devices that is needed for a difficult intubation. The other option which many people have adopted now is for elective surgeries to get a teleconsult where you will assess an airway assessment sitting in your pre-anesthetic clinic. And this is something which probably has become a new normal in anesthesia practice. Now, in the pre-anesthetic clinic, I wanted one more point to emphasize in this COVID pandemic is many patients who had had COVID before come for elective surgeries or semi-urgent surgeries. You have to keep in mind the possible post-COVID sequelae because of persistent of inflammation. And few of the factors which are very crucial for anesthesiologists. Number one is myocarditis. So it becomes important if you notice an arrhythmia in the patient, or if the patient complains of difficulty in breathing on exertion, it's very important to see the left ventricular function, rule out myocarditis, number one. Number two, many of them might have residual pulmonary dysfunction. So it's important to see room air oxygen saturation and if need be a pulmonary function test. Very important as an anesthesiologist. And a lot of them complain of quite a significant fatigue and they are in negative nitrogen metabolism. And the perioperative period may make it worse. And fourth point of relevance is they are very thrombotic in the post-COVID phase. And many patients have come and presented with several areas of ischemia, including a gangrene of the lower limbs, gangrene of the upper limbs, stroke, a cerebrovascular accident, and an anesthesiologist during the pre-anesthetic evaluation has to keep this in mind. And all the post-COVID patients, several of them have been put on anticoagulants and antiplatelets, and this needs to be evaluated before we take them for surgery. There's something very important that if they're COVID positive, wait for 14 days until it is an emergency surgery. And when you use general anesthesia, several methods have been adopted. Basically, the anesthesiologist has to be in a PPE kit or at least an N95 mask with a face shield if they're going to intubate a patient who is RT-PCR negative. If it's positive, then they have to definitely be on a PPE kit. And laryngoscopy is done preferably with an indirect laryngoscopy, but also these chambers, the anesthesia intubating chambers have become very popular. And this could be used to decrease the aerosol generation generated from affecting the intubating anesthesiologist. This is what we use in our unit. There is a suction port which is connected, and post intubation, you always keep 20 minutes. This is kept in situ to make sure all the aerosols generated are sucked out. I also would wanted you to focus on this, the HMEF. So it's very important that you use HMEF. There are two types of HMEs, HME and HMEF. F is with a filter, which filters the viral particles, viral organisms. So you have to use HMEF in the patient end, and one HMEF should be in the expiratory port towards the machine end. This is to prevent any contamination of the machine. The HME filter which we use should be, near the patient should be changed for every case, but the HME filter that you use in the machine end can be changed at the end of the day. So this is how the intubation bay looks like. It's a very good way to do it. And the pandemic has clearly shown that regional anesthesia has emerged pretty strong because it's not aerosol generating procedure. And when you incorporate regional anesthesia, you have to make sure that it is 100% successful. You have to use either a peripheral nerve stimulator and ultrasound to make it happen. And very importantly, it's best to avoid conscious sedation in these patients during regional anesthesia, because if you sedate them and then give a block, there is a possibility there can be a tongue fall and airway manipulations have to be done, which can generate aerosols. And during regional anesthesia, if you want to supplement oxygen, it should be less than 4 liters per minute. It's mainly because if you do administer more than 4 liters, this itself can generate a lot of aerosols. I would prefer not to use a nasal prong, and I would like to go for a mask, face mask, and give less than 4 liters per minute. And in case if you need to convert the patient, the anesthesia is not taken well, regional to GA, then would strongly advocate to go for giving GA with a full PPE. These equipments, the PNS and the ultrasound, make it very convenient to make it 100% good block. So this is the time to evolve and give excellent quality of care with the help of ultrasound. And when you use ultrasound, it becomes very important that you make sure that it doesn't act as a fomite in transmitting infection, and you need to cover the entire sheath and the probe. The regional anesthesia seems to be of great help in this situation because it decreases the blood loss then compared to general anesthesia and the surgical patients, and hence the need for transfusion becomes less. It has been found out that perioperative blood transfusion results in immune suppression, and especially if the patient is positive to COVID, and immune suppression can result in more immunological damage and inflammatory damage and multi-organ failure in your patients. And regional anesthesia is also good because it acts as a part of multimodal analgesia, and the post-operative need for giving sedatives becomes less. And less sedatives means less airway involvement and tongue fall, considering the fact that 52% of the surgical population in India have got obstructive sleep apnea syndrome. So it is crucial that you plan your strategy of the post-operative period as well. And it's a good time that as anesthesiologists, we start using gadgets like PCA pump, elastomeric infusion pumps to our patients, and site-specific analgesia for our patients, because the VAS score remains less than 3 when you use these devices, and also because of the fact that the patient will not repeatedly call a healthcare worker to assist in decreasing the pain. So the number of interventions that needs to be done becomes less. So this thought processes should come into play, and we should clearly strategize on how we are going to anesthetize our patients. So the new normal is in the perioperative period, an anesthesiologist should go that extra mile in making sure that he offers the right kind of anesthesia to his surgical patient, and not to refuse giving anesthesia to any patient, number one. And number two, at the same time, he takes adequate precautions to make sure that he does not get infected, nor he allows his healthcare worker in getting infected. I take this opportunity to sincerely thank the organizing team of the Railway ISA for giving me an opportunity to share my thoughts. Thank you.